Welcome to the performance story for HealthVision's Delmarva Practice Transformation Network, a PTN under the Transforming Clinical Practice Initiative, TCPI. At HealthVision's Delmarva, we are guided by the following guideline: meeting our members where they are to improve their practice, achieve exemplary outcomes, and provide value, enhancing their ability to thrive in an alternative payment model world. How do we do this? By adapting the evidence-based guideline model to our practice transformation efforts. In evidence-based guidelines, clinical experts use evidence-based guidelines and the input of the patient and family in regards to their values, needs, and preferences for high-quality decision-making. In our transformation model, we also use an evidence-based guideline, the TCPI Change Package, and our practice advisors use their expertise along with the input and views of the provider and practice, including their values, needs, and preferences for effective transformation. And we've been very successful when using this model. We have achieved many of the aims of TCPI, including the first aim, enrollment and phase progression. On that aim, we've achieved 154% of our target enrollment, and 40% of our clinicians have achieved exemplar status. We do this by focusing on specialty care practices who partner with our local ACOs, and we're building a strong medical neighborhood. We've directed our efforts at practices who are highly engaged to ensure top performance. In the area of patient outcomes, almost 45,000 patients have shown improvement in the areas of diabetes, hypertension, obesity, or LVSD. And we've achieved 93% of our overall quality commitment. By introducing the concepts of accurate data collection, aggregation, and analysis, along with patient engagement, team-based care, and evidence-based guidelines, we've helped practices to improve outcomes for their patients and excel in MIPS. On 3 of our measures, we've not only achieved our target, but also the 8th decile benchmark for those measures in the MIPS system. On Aim 3, reducing unnecessary utilization, we've reduced 30-day all-cause readmissions by almost 1,500 cases. That's 38.62% of our commitment, and it only includes full data through 12 of 2018 for one state. Once we add the Delaware data next quarter through the end of calendar year 18, we expect to be very close to our commitment results. We've been doing this working with hospitalists, specialists, and our ACO partners. And in doing that, we're impacting this readmission rate by ensuring that post-discharge follow-up in the community is occurring and that standard evidence-based guidelines are adopted. On Aim 4, reducing costs, our practices have contributed a total of $19.9 million in cost savings. That's 133% of our revised $15 million commitment. We've quantified significant cost savings from our readmission reductions, as well as an estimated savings from our many quality improvements. And finally, Phase 5, reducing unnecessary testing. We've reduced this by 2,047 cases, and we've met 232% of our 4-year target. This was a challenging aim for us, but we've achieved success by implementing the use of evidence-based guidelines in the emergency department and the radiation oncology setting. We've collaborated with ACR and ACEP, and this has helped to encourage practice buy-in and has sparked interest from our partner hospitals to spread this initiative beyond TCPI. Let's take a look at 3 of our high-performing benchmark clusters: hypertension, A1C control, and ED testing reduction. For hypertension, our cohort includes 44 practices of 187 clinicians caring for over 30,000 patients. We started by optimizing their EHR utilization to ensure accurate data collection, analysis, and aggregation of both the individual patient outcomes and the population. And then we shared this data transparently with the entire treatment team and used a team-based problem-solving approach to address gaps in performance. Some of the things that we implemented were team-based care, patient engagement, including motivational interviewing and teach-back, and care coordination to focus on high and emerging risk patients. In this particular population, we've also used patient self-management tools and EHR-based technology like the portal to allow patients to self-report their information easily. For hemoglobin A1C, our cohort consisted of 18 practices and 111 clinicians, treating 5,000 patients. Again, we started by optimizing our data collection for accurate data, and once we had accurate data, transparently shared that with the team, and using that team-based problem-solving approach, designed new ways to address performance gaps. Again, key in this was team-based care, patient engagement, and care coordination to focus on high and emerging risk patients. And finally, the ED testing reduction benchmark cluster. This covered 4 practices and 142 clinicians with over 30,000 patients. And we were also assisted in this one by 2 of the SANs, American College of Radiology and the American College of Emergency Physicians. Using ACR's RScan and ACEP's education resources, we engaged partner practices at 2 hospital EDs to adopt Choosing Wisely evidence-based guidelines. We're currently hardwiring this into the Epic clinical support system to ensure sustained results. And we're expanding to additional tests and other departments within the hospital system to grow our success. So we've been able to develop a number of practices into exemplar practices. But one of our goals for year 4 is sustainability, ensuring that they continue to be able to perform as time progresses. So we're preparing our practices for the future by providing them with toolkits such as PDSA, care coordination, team-based care, and patient-family engagement toolkits. We've created a sustainability checklist so that they can be sure that they have all the pieces that they need in place. And we're providing ongoing alternative payment model education to our practices. In addition, we will be providing a networking opportunity with payers and providers at our 2019 Health Visions Delmarva PTN Quality Conference to be held in June. But sustaining the performance of our current TCPI practices isn't enough. We want to spread our success and share the secret of success with others. In order to do this, we're inviting our partner hospitals and ACOs and other interested parties in our states to the 2019 Quality Conference in June. We're sharing our exemplar practice stories with them through hospital newsletters, hospital websites, and medical society newsletters. We're sharing tools and resources with our partner ACOs for consistency, and we are facilitating introductions of our exemplar practices to payers so that they can begin discussions for alternative payment model participation. And that's the way we do it at Health Visions Delmarva Practice Transformation Network. We start with engaged and committed practice leadership. We make sure that they have accurate data. We share that data transparently with the team. We incorporate the voice of the patient and family. And using a team-based model of performance improvement, we create a transformed practice, leading to exemplary outcomes, experience, and value. Thank you for listening to our performance story today, and we really look forward to helping you engage with our practices as you move forward. Thank you.